Hi, Dr. Lennox Hoyt, fellowship-trained urogynecologist and pelvic surgeon. And the question I get often, and sometimes I get it as I sit looking at my new patient for the first time, is what should I bring to my appointment with my urogynecologist, my pelvic surgeon? Now that question has embedded in it the assumption that you found the right surgeon, the right kind of doctor to deal with your problems. So you want to talk to somebody, you want to see someone who's experienced, who's got a long history of dealing with complex pelvic floor disorders, who has a good track record of solid outcomes, and takes a good thinking, systematic approach to solving your problem. Once you're in the office of that person, and again, I've had patients come to me with reams of records, lots and lots of paper, saying these are what the 17 doctors that I've seen and this is what they've done. Usually not the thing that I want to be looking at when I first see you. The thing that's important that has long been a truth in medicine is that 70% of the diagnosis of a problem comes from the history from the patient. So when you come to see the urogynecologist with a pelvic floor disorder, the thing you need to bring is yourself and a good understanding and a good narrative of what your history has been. I've had women come and tell me, well, this one said this and this one said that and this other doctor said this. That really is not helpful. At the outset is the following. What's wrong? Why are you here to see Dr. Hoyt, your surgeon? What's the issue? And issues like symptoms, I have pain when I try to have intercourse. I leak stool. I leak urine. I can't empty my bladder. I can't pee. It hurts when I do this. That's the basic set of symptoms that you need to come with so that the person listening to you can ask the next set of questions, which is, how long has it been going on for? What have you done about it? Who's treated you before? What makes it better? What makes it worse? That leads to a framework that your practitioner, your surgeon, your doctor can actually build for himself or herself to understand what is driving this problem. Why is this person coming to see a total stranger? What's the problem? Why did they travel 300, 400, 500 miles to come to see me? The reams of paper don't help with that. What helps is your thoughtful explanation, if you can, of what's wrong. Beyond that comes another set of questions. What kinds of things have been done about it? And at that point, we can ask questions of, have you had a surgery before? Have you had diagnostic testing? What did the test show? And then I can ask the question, do you have that test result? Do you have the result of that MRI or that urodynamic testing? Do you have the result of that ultrasound? For example, we can look at those at that point. So at that point with the interview, with a discussion of what your symptoms are, the history, if you will, of the situation, the next step is the physical examination. So the next portion of the insight into the problem comes from examining you. And so the exam usually is a traditional exam, listen to heart and lungs, check the thyroid, check the neck, check the abdomen, for example, look for scars and masses and hernias and things like that, ostomy bags and so forth. And then in my case, in the case of a urogynecologist, we're going to want to do an examination of the pelvic tissues. And that's where another chunk of information about the problem comes into play. So the physical exam will reveal whether there's good reflexes in the pelvic floor, whether there's good pelvic floor strength, whether there's prolapse, whether the tissues are atrophied or well estrogenized, whether there's tenderness or active trigger points in the pelvic floor muscles. Is there obstruction in the rectal exam? Is there evidence of rectal prolapse? Is the anal sphincter intact and so forth? So there's a whole collection of information that comes from the physical exam where when you put it together with the history, that's called an H&P, affectionately known as history and physical, together you have a beginning good understanding of what the problem is. At that point, when you incorporate, these are the things that were done before. She had this surgery, she had this test, she had this study, she had this scan, she had this GI evaluation, she had this colonoscopy. All of those things can come together to start making the beginnings of a plan for understanding the problem at the next level. And that's the testing level. And that's something that you can then lead into discussion about. But the bulk of the information that you bring to your first visit with your urogynecologist is yourself. And a good specification or narration of the history. What's wrong? How long has it been going on for? What makes it better? What makes it worse? What have you done about it? I hope that helps.
So I think the most important thing that a patient can bring to a surgical appointment for pelvic surgery complications is herself, so that she can be examined, It is helpful if she has operative reports from the prior surgeries that she's had done. That would certainly help the surgeon identify what may be at issue with the surgical complication, but she needs to bring herself and her list of complaints related to the condition that she has.